You must imagine that it's 1915. Internships have just become the most high-level, advanced form of training in the world. 20 years ago, most physicians who graduated medical school had never even done an internship. They finished medical school and went right out and practiced. There was no such thing as a subspecialty fellowship. No such thing as radiology, practically. Even residencies were virtually unheard of. So the United States government and the American Association of Medical Colleges get together and say, well, now everybody's finishing this 1 year of training post-medical school, and then you're going to be unleashed, released upon the world. So we want to create a standardized test at the end of your internship to show that you are qualified to be a good, licensed general practitioner, and that's what Step 3 is. Step 3 is the archaeologic remnants of the test given starting in around 1915, just at the time that internships became the standard of training in the United States medicine. Residencies didn't become standard until around the time of the Second World War, and subspecialty fellowships came around in the 50s and 60s. So just think about it. It's 1915. There's no beta blockers. There's no ACE inhibitors. There's no antibiotics. There's no MRI, and there's no CT scans. X-rays have just been around for about 20 years, and all that diagnostic testing and treatment doesn't exist. So what you could learn could be contained in that one postgraduate year. So you must think about what the archaeologic remnants of Step 3 was in order to say, well, what should I study? Well, it's 1915, and I'm about to become a general practitioner in Nebraska. I don't need to study heart-lung transplants. I don't need to study complex things. I don't need to study complex tertiary care medicine as much as I need to know high blood pressure, diabetes, hyperlipidemia, smoking and drinking too much, UTIs and otitis media, depression and general obstetrics. And what's the most common reason to visit a gastroenterologist in the United States? Wilson's disease, hemochromatosis, primary biliary cirrhosis, Henoch-Schönlein purpura. The most common reason to visit a gastroenterologist. Kriegler-Najjar, Dubin-Johnson. Diarrhea? Almost. Similar. Irritable bowel. Irritable bowel? You mean fussy people get crampy pain and you get a bowel movement and you feel better? Irritable bowel? No etiology? All the tests are negative? Chronic fatigue syndrome of your bowels? Yeah. Yeah. That's the most common reason to go see the gastroenterologist. The most common reason to go see the gastroenterologist. What do I study for Step 3? What are the top 10 causes of death in the United States? And what are the top 10 reasons to go see the doctor? That's what I study. Pneumonia and bronchitis and depression and otitis and sinusitis and UTIs and routine pregnancy and high blood pressure and diabetes. Because you're in 1915 and 1920. You've just completed your internship, and the basic function of Step 3 of USMLE is not to show excellence. It's to show safety. That you're safe. Are you safe? I'm about to give you a license to practice medicine. I'm about to give you this license. And that means all of a sudden you become empowered with the society by an awful lot of independence. So I better make sure you're safe. So that's the fundamental issue, and that's what you're studying for USMLE Step 3. Not excellence, not complexity, safety. Safety. First hour of management. Now, a lot of routine office management in primary care medicine is infectious diseases. And there are a nauseating number of infectious disease cases. Now, we're not going to do all those cases in class. We'll do probably about half of them. Remember what I said, that these materials were originally designed for a 6-week real long course, and we're giving you all the materials in that 6-week long course, of which we cover surprisingly 70 to 75% in class of 6 weeks of material. We've got 6 weeks of material and put basically a month of it into 10 days. But we don't need to do 3 pneumonias, 3 meningitises. Once we've done 1 vaginitis, we've already learned how to take care of any vaginal problem you're ever going to have. We don't have to do 3 vaginitises, do we? No. Okay. So, infectious diseases. Let's look at some general principles. Some general principles in infectious diseases. Number one of which is, when they ask you what is the most accurate diagnostic test, try to answer the culture. When they say, which of the following is the most specific diagnostic test, try to answer the culture. On the other hand, never answer, wait for results of culture. Never answer, wait for results of culture. But you just said it was the most accurate, the most specific. Yes, I said that. I also said don't answer, wait for results of culture. In infectious diseases, it's almost always empiric therapy. So, when you think about it, otitis media. What's the most accurate diagnostic method for otitis media? What's the most accurate diagnostic method for otitis media? What? Age. That's the most accurate. Age. You're 40. You don't have any otitis. You're 7. You have it. The most accurate, not age. Look in the ear. For what? Looking for bulging. Looking for bulging is always an admirable and important thing to do. But it's not the most accurate. But it is one of the most common wrong answers. The most accurate method of diagnosing otitis media. Culture of what? Aspiration of the tympanic membrane. Tympanocentesis. For culture of the tympanic fluid. Now, some of you might say, well, why don't you just tell us the answer? Why do you keep asking? You're supposed to tell us. And the answer is, that's just the way we are. I can't just tell you. If I could just tell you, you could go and read the notes or read Swanson's or read any other textbook and it'd be fine. But we're not that way. We are opaque to knowledge. It bounces off of us. It bounces off of us. There's nothing particularly unique about the data in these notes. Not the data, not the answers anyway. There's nothing unique about it. As a matter of fact, it's rather boring because it's supposed to represent a consensus statement. These cases you have in front of me, right now we're filming in California, right? But it's the same exam that's being given in New York, is the same exam in Florida, is the same exam as in Texas. So the cases represent national standards of care. Not my personal practice patterns. Not the CF, the Conrad Fisher MLE. So the data is not unique. So we must put our minds in the form of that question so we become receptive. The most accurate method of diagnosing otitis media is a tympanocentesis in a culture. So you do a tympanocentesis on every case of otitis media. No? Hello? No? But isn't tympanocentesis the most accurate? But you wouldn't do it? I just said that it's the most accurate. So you wouldn't do it on every one? No, you wouldn't. It's the most accurate, but I didn't say what you do. You said, what's the most accurate? What's the most accurate is tympanocentesis. You didn't say what you do. If I said, what would you do? I'd just treat it. I just treat it empirically. What is the most accurate diagnostic test for sinusitis? A CT or an X-ray is the most accurate for sinusitis. Or an MRI. CT. We do know that hysterosalpingogram will not be one of the answers. The most accurate diagnostic test for sinusitis is? Let me rewind the tape. Ready? With infectious diseases, the most accurate diagnostic test is the culture. When they say, which of the following is the most specific diagnostic test, answer the culture. On the other hand, never wait for results of the culture. Fast forward. What's the most accurate diagnostic test for sinusitis? Brilliant! Ralph Waldo Emerson in Self-Reliance says, the only real satisfaction comes from the triumph of principle. Now, I don't know if that's true because apparently Ralph didn't get out enough. But on this principle of culture is the most accurate thing. You cannot stain a CT scan. You can't culture an MRI. You can't get sensitivity testing on an X-ray. So in infectious diseases, the most accurate diagnostic test has to be the culture because you can't get a specific organism otherwise. But I want you to notice something. Do not be under the illusion that you have come here just for data. We're in an information age. On a cellular Palm Pilot, You can have all the information of known world passing through your hand any moment. But we do not absorb. So it's not just data and information you're here for. Look at this experiment we just did. I start here and I go, the most accurate and specific diagnostic test is a culture and infectious diseases. And I say, what's the most accurate diagnostic test for otitis media? Age, exam, bulging, clinical? No, tympanocentesis in the culture. Because culture is the most accurate. Then I say, what's the most accurate diagnostic test for sinusitis? CT, X-ray, MRI. You see? That's how we are. Once we realize that we're so programmable, once we realize that an IBM 486 computer has more ease of change and more consciousness than we do, I think I got a handheld razor that has more programs than most of our minds. Because you don't have to keep telling the handheld razor and the computer. The most accurate diagnostic test is a culture. Tympanocentesis, sinusitis, aspirating the sinus. Brain abscess, what's the most accurate diagnostic test?
Biopsy culture.
Biopsy culture. Yes, it's true. Lung abscess, what's the most accurate diagnostic test? Culture of what? Culture of the effusion, no. Thoracoscopy, thoracentesis, and aspirating the lesion. Now, if you do it this way, you can know about things even when you have not studied them. If you do it the old way, you have to go to each disease and learn it individually, collecting each piece of data. This way, if you do it on principle, you could go to a particular disease you've never studied before and know the answer without having been there. That's so much easier. Other than that, learning each individual disease one by one is like an intellectual enema. You can receive it, but it's a stretch. It's uncomfortable. And when you go into test day, it doesn't stick. It doesn't stick. Okay. Now, this person, 5 days of fever, cough, productive of blood, pleuritic pain. Okay, we got a guy who says, I'm an intravenous drug user. User. Don't be judgmental. Don't be judgmental. We don't say abuser. Don't be judgmental. Got to be objective, clean, non-judgmental. American society. Everything's okay. Everything is beautiful, baby. Nobody's good. Nobody's bad. Everybody's nice and homogeneous. User. The same way you can't say prostitute in the medical literature. Not prostitute. Oh, no. Too judgmental. Too judgmental. What would be the proper term for prostitute? Glenn? Is that? No? Ho. Yeah. So, a drug user, and he says, hi, I shoot drugs for a living and I have a fever. I shoot drugs for a living and I have a fever. That by itself is enough to tell you that there's endocarditis. That by itself, to say, I shoot drugs for a living, injection drug use plus a fever equals endocarditis, is enough. That by itself is enough. The fact that this guy's got a murmur and a fever, woo, woo, woo. Murmur plus fever, absolutely. That is enough. By the way, what valve is this? What valve is this? Lower left sternal border, lower left sternal border? Tricuspid. Ready? APTM. APTM. Apartment M. Aortic, pulmonic, tricuspid, and mitral. Aortic, pulmonic, and tricuspid, and mitral. Let's see if I can make this clearer. Therefore, T, apartment M, tricuspid valve. Now, you can also notice that this guy, it's somewhere in here now, the cases are all smushed up, I can't see anything. There's got a cough in here somewhere, right? Yes, he's got a cough in here. He's got a cough in here, and he's got a cough that's productive of blood. Does endocarditis cause a cough? No. Endocarditis by itself does not cause a cough. Endocarditis by itself does not cause a cough. Does endocarditis cause hemoptysis? No. Does endocarditis cause chest pain? Does endocarditis cause chest pain, pleuritic chest pain? No. Not really, no. So he's got fever and a murmur, that's enough for endocarditis. He's got, I shoot drugs for a living, and I've got a fever, that's enough for endocarditis. But cough, hemoptysis, pleuritic chest pain, these things are not consistent with endocarditis. That's more pneumonia. Fever, hemoptysis, cough, chest pain, that is more pneumonia. Now you notice that when you look at this guy, that you notice that he's got no Roth spots, no Janeway lesions, no Osler's nodes. He's got no Roth spots, no Janeway lesions, no Osler's nodes, no Roth spots, no Janeway lesions, and no Osler's nodes. And it doesn't matter. No, it's because you don't ever see them. These are irrelevant. This sort of stuff that they beat into your brain in medical school about splinter hemorrhages and Roth spots and Janeway lesions and Osler's nodes are virtually never seen anymore. When Roth wrote about his spots, Moritz Roth was a German pathologist who lived in the 1870s, worked and wrote about spots in the 1870s. Roth was writing at a time 70 years before the invention of antibiotics. Same thing with Janeway. Osler wrote the first major textbook of of medicine, of all of medicine, in 1890, Principles and Practice of Medicine. 700 pages, all by himself. Out of all the infectious diseases in that book, the only one that had 100% mortality was endocarditis. Endocarditis, untreated, has a higher mortality than plague. Plague has a 30% mortality. Smallpox has a 30 or 40% mortality. Ebola has a 70% mortality. But endocarditis, untreated, has 100% mortality. Everybody dies. So when Roth and Janeway and Osler and Splinter all lived, Splinter's hemorrhages, no? They were talking about a disease that was the way that you and I would think of as metastatic breast or colon cancer. 18 to 24 months with no effective therapy, everybody dies. So therefore, endocarditis at that time was like metastatic cancer, an incurable, chronic, progressive disease to death. You are going to look for fever and a murmur, or fever and a change in murmur. Fever and a murmur, or fever and a change in murmur, and that's good enough for you. This is tricuspid valve. Sure, it's tricuspid valve, because it's like a person with carcinoid who's continuously bathing the right side of his heart in evil, abnormal things. So he's continuously bathing the right side of his heart with staphylococcus. Every time he goes and shoots up a half a pound of staphylococcus into the right side of his heart every day. So he's got tricuspid valve involvement, which is the lower left sternal border. APT, apartment, M, mitral, aortic, pulmonic, tricuspid, and mitral. This history, this physical, the best initial test. Are you covered up? What did we talk about this? Didn't we discuss this before? Do you need a spanky? What's going on? What did we talk about? How are you supposed to look at this and judge this as a single best answer question? Because this is a great single best answer question. They could ask you, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What's the most accurate diagnostic test? What's the best initial therapy? So you have to practice. You have to practice by covering it up and saying, how would I recognize that this is endocarditis? Well, I have fever and a murmur. Except there's something else here because he's got cough, shortness of breath, pleuritic chest pain. The best initial diagnostic test in endocarditis is always blood cultures or echo. Well, isn't that the issue, isn't it? That's what it comes down to. Is it blood cultures or echo? Hysterosalpingogram will not be one of the answers. You walk into the test and you say, look at these things. Look at this disease. Look at this disease. There's only a limited number of answers for every disease. You go in with endocarditis. Well, maybe somebody might put EKG, blood cultures, echo. But how many things can there be? There can't be that many answers. Head CT is not one of the answers. Urinalysis is not one of the answers, the most accurate. It comes down to, is it echo or is it blood cultures? And echo is always the most common wrong answer. Blood cultures is always first. It's always blood cultures first. It's always blood cultures first. Hadashol. Okay? Because cultures that are positive and an abnormal echocardiogram is endocarditis. I hate to be so simplistic, but that's just the way I am. Now, if you look at the big textbooks of medicine, you go, wait a second. How do they get 6.5 pages and 7 pages in Harrison's textbook of medicine out of, forget about Roth spots, Janeway lesions, and Osler's nodes, look for a fever and a change in murmur, check blood cultures and do an echo and you have endocarditis. How'd they get 5 pages out of that? The answer is, I don't know. The other thing is, the first 5 pages are all about pathophysiology of fibrin platelet plaques accumulating on the valves of experimental rabbit endocarditis. Yeah, that's nice. What do you do in the end? I get the blood cultures. When the blood cultures are positive, I get the echo. When I have positive blood cultures and an echo showing me a vegetation, I have endocarditis. Thank you very much. And then you treat what you find. You treat what you find. Don't worry about Osler's nodes, splinter hemorrhages, Roth spots, hematuria. These 2 things. And then standard of care is 4 weeks of therapy. Except this guy gets 6 weeks. Why does this guy get 6 weeks? Why does this guy get 6 weeks of therapy? Standard of care is 4 weeks. Why does this guy get 6 weeks of therapy? Because he's got not so much pneumonia, but multiple abscesses. He's got embolic phenomena. And when you have embolic phenomena, you've got to extend the therapy. They're like little miniature abscesses. Little miniature abscesses. When you have enterococcal endocarditis, and you have a tougher bug, when you have an artificial valve, when you have a prosthetic valve, you have to extend the length of therapy with enterococcal or prosthetic valve or embolic phenomenon. You extend the length of therapy for these diseases because you have anatomic problems. Emboli, little abscesses, anatomic problem. Prosthetic valve, anatomic problem. Enterococcus, a tougher bug. You extend the length of therapy. You extend the length of therapy. These are the strongest indications. Now remember, I know that we said here that you don't ever wait for results of culture, but the culture results are there. That's because when you're looking at a 2-dimensional image in a piece of paper, you don't have the element of time moving the clock forward like you do on CCS. So we have to give you the tests and the results all at the same time. Because it's the only way to write it out. We can't have, you're reading and then, 2 weeks later the tests appear, the result appears on the paper. So it's all at the same time, although you will not have the results of a culture at the beginning. You won't have the results of culture at the beginning. Okay. Now, you have staph in endocarditis when you have injection drug users. When you have little old ladies, you have strep and subacute bacterial endocarditis. Staph and strep and staph and strep. And in general, what are the best staph strep drugs? Neafcillin, oxacillin, cloxacillin, dicloxacillin, and nafacillin. So the best staphylococcal drugs, which will also get strep, although penicillin by itself, regular old penicillin, is better for strep. The best staphylococcal drugs are oxacillin, cloxacillin, dicloxacillin, and nafacillin. Ox and clox and diclox and naf. When are you going to use methicillin? Never. But what about for methicillin-sensitive Staph aureus? It's methicillin sensitive. Go ahead, say it. When are you going to use methicillin? It's methicillin sensitive. Come on.
You use it for culture.
It's not exactly, I didn't quite get that. When are you going to? When it's sensitive. That's the wrong answer I'm looking for. It's not when it's sensitive. You use methicillin when you want to kill somebody's kidneys. That's it. Good. When you want to kill the kidneys. When you say, I don't like that patient. I want to hurt their kidneys. This looks like, you look like someone who'd like to urinate eosinophils. And you say, you look like you'd like to urinate eosinophils. I'll give you some methicillin, and you can urinate eosinophils. So methicillin is never used. But wait a second. Why do we talk about methicillin sensitive and methicillin resistant if we don't use methicillin? And the answer, yes, well, that's what methicillin sensitive and resistant means, MRSA, yes. But even the methicillin sensitive, when do we use the methicillin? Never. What? You don't use methicillin for methicillin sensitive Staph aureus? No. Where's all the Rocky Mountain spotted fever? Not in the Rocky Mountains. What does the lupus anticoagulant make you do? Clot. Oh. It's one of the great ha-has of medicine. You never use methicillin for methicillin-sensitive Staph aureus. Rocky Mountain spotted fever is not in the Rocky Mountains. The lupus anticoagulant makes you clot. Methicillin causes allergic interstitial nephritis and causes renal failure. So we actually never use it clinically. When we're talking about methicillin-sensitive and methicillin-resistant, we're talking about sensitive or resistant to ox, clox, diclox, and NAF. Ox, clox, diclox, and NAF. Yes, that's right. And you say to the patient, do you have any allergies to medications? And he says, why, yes, I'm allergic to penicillin. Well, what happens to you when you take penicillin? Well, I get a little rash. I get a little rash. What do you use when you get a little rash to penicillin? Not Vanco. Cephalosporins. Cepha 1, Cepha 2, or Cepha 3? First generation cephalosporins. Cefazolin. Or cefazolin, depending on where you put the emphasis. Cefazolin or cefazolin, depending on where you put the emphasis. So you use first generation cephalosporins in patients who have little allergies to penicillin. The amount of cross-reaction is less than 5%, and if the penicillin allergy is just a rash, do not worry, do not fear. Hold my hand. Take my hand. I'm reaching through the screen. Touch the screen. Touch the screen. Okay. It's okay to use cephalosporins in people who have little rashes to penicillin. Don't let go. It's all right. I know you've been hurt before. But I'll never hurt you. It's okay. There's less than a 5% cross-reaction. There's less than a 5% cross-reaction between these two. And it's never anaphylaxis. If the person just says, I have a little rash, But now you say to the person, listen, do you have any allergies? Yes, I have an allergy to penicillin. Well, what happens to you when you take penicillin? Well, I get a rash. Anything else? Well, yes, I also got hypotensive, and I was on dopamine and norepinephrine and neosynephrine. I got intravenous steroids. I had to be intubated. I got a tracheostomy. I had laryngeal edema and stridor. I got a tracheostomy, and I nearly died. Oh. That's bad. Well, I guess we won't use cephalosporins then. You see, if they're cross-reaction, if the reaction is anaphylaxis, then don't use the first-generation cephalosporins. With a life-threatening penicillin allergy, you could use either vancomycin. Here's something new for you. Linezolid. Linezolid. How many people here have even heard of linezolid? Oh, that's so much better than it is. So I have 4 people raising their hands. Probably another 4 people want to raise their hands, but they're afraid I might ask them about it if they raise their hand. All right, that's better. It's already coming up. Linezolid. All right, just a little thing to see. Zyvox. Linezolid or Zyvox is now the first drug besides vancomycin that will actually treat methicillin-resistant Staph aureus and will treat staph with no cross-reaction with the penicillins or the cephalosporins. Or macrolides, if it's a minor infection. Minor infection, macrolides. More serious infections, vancomycin or linezolid, in terms of staph and strep and staph and strep. Now these drugs, what I'm giving you here, I'm giving them to you roughly in the order in which I want you to use them. You notice that I put vancomycin down here. Yes, I put vancomycin down here because I don't want you to use it first. Vancomycin is not as good as these drugs are. Vancomycin is not as good. It's not as efficacious. It's not as good a killer of staph and strep. It doesn't kill as well. Vancomycin is for two reasons. Methicillin-resistant Staph aureus, or I have a life-threatening anaphylactic reaction to penicillins and I can't use penicillins or cephalosporins. So if this patient, he gets little oxclox, dicloxanaf, or first-generation cephalosporin, or if he has an allergy, or if you change this one word from methicillin-sensitive, and you change this one word from methicillin-sensitive to methicillin-resistant, and then it becomes vancomycin. Now, aminoglycosides are almost always for what group of from what group of organisms? Aminoglycosides are to treat what group of organisms? Gram-negatives. This is one of the exceptions where aminoglycosides, like gentamicin, are used synergistically for endocarditis. Aminoglycosides are used synergistically. Oxacillin and gentamicin, nafacillin and gentamicin, vancomycin and yentamicin. The beta-lactam punches a hole in the cell wall, and then the aminoglycoside rushes through the hole in the cell wall and kills the ribosome. Let's close up the wall with our English dead. Okay, so that is the management of endocarditis. Now, prophylaxis. Now, to need prophylaxis, you have to have a significant cardiac defect, and you need to do something dirty. You have to have a significant defect and a bacteremia causing procedure. A significant defect and a bacteremia causing procedure. Okay? You need both of those things. Now, obviously, if you get all of your teeth pulled out for dentures, that's a bad procedure. And obviously, if you have aortic stenosis or an artificial heart valve, they need prophylaxis. Aortic stenosis, mitral stenosis, sure, those need prophylaxis. You didn't have to come here for those. But the prophylactic question, please match the following cases to the most appropriate prophylaxis. Aortic stenosis, mitral stenosis, prosthetic valve, sure, they need prophylaxis. If you have a bacteremia-causing procedure, getting the endocarditis. But what about mitral valve prolapse? What about a ventricular septal defect? What about a cardiac catheterization? I might have aortic stenosis, and now I'm going to get Swan-Ganz catheterization, angioplasty, angiography. What about I'm going to get all of my teeth pulled out, and a hemicolectomy, and a colposcopy, and I have a pacemaker in place? What about a cesarean section? I have aortic stenosis, mitral stenosis, and mitral regurg, and I'm going to get a cesarean section. Do I need endocarditis prophylaxis? What about a previous bypass? I've had previous quadruple bypass. I had previous quadruple bypass, and today I'm going to get cholecystectomy, cystoscopy, prostate biopsy, and a waxing. IHSS, also known as hypertrophic obstructive cardiomyopathy. Idiopathic hypertrophic subaortic stenosis, and now I go get my teeth cleaned, a colonoscopy, and a cholecystectomy. Okay. Mitral valve prolapse. Do you have to prophylax mitral valve prolapse? If there is regurg. Yes, if there's regurg. Yes, if there's regurgitation. By the way, what is the most common predisposition to endocarditis? Which of the following is the most common predisposition to endocarditis in the United States of America? This is not the overwhelming look of response that I wanted. This is the bilateral Bell's palsy. Don't be scared of me, honey. Okay? You can do whatever you want. Think of this like group therapy. Think of this like group therapy. It's just another anonymous educational contact. You can do whatever you want. You don't live with the consequences. IV drug use. No, there's not that many. No, there's 600,000 intravenous drug users in the United States. 600,000. That's regular, meaning once a week. Not I did it once in college but didn't inhale. But it's not the most common. What? Previous endocarditis. Oh, this is like a Zen koan, the sound of one hand clapping. What is the most common cause of endocarditis? Previous endocarditis. But how did you get the endocarditis before? More previous endocarditis. But how did you get that? More previous endocarditis. Oh, there's like M.C. Escher, you know what I mean? That's good. That's artful. You have a rewarding career in government ahead of you. No, not previous endocarditis. The most common risk for endocarditis in the United States is? Mitral valve prolapse. Oh, you mean what you were just saying? Right? Yeah, like what we're just saying here, you know? Mitral valve prolapse is the most common. Might be a normal variant in up to 5% of women. There's a lot of women around the country. I've read. Okay? But the thing is that if you have 4% of all women, and there's 140 million or 150 million women in the country, ooh, that's a lot. That's millions and millions and millions of people with mitral valve prolapse. If there's regurgitation, you need to prophylax. Ventricular septal defect. Do you need to prophylax a ventricular septal defect? Think. You can't just wait to be told. Think. Do your thinking now, and you know what happens? When you walk in on test day, you have all that stuff in your head. Do you think that ventricular septal defects give a lot of turbulence in the heart or not? Yes. Ventricular septal defects give a lot of turbulence. Atrial septal defects don't. Oh. Ventricular septal defects. I've got a hole in my heart. But the hole is in between the right and the left ventricles. And in between the right and the left ventricles, there's a huge difference in pressure between the right and the left ventricle. You've got a hole in that septum, and a huge regurgitant jet of blood shoots from left to right, hits that wall, damages the endothelial lining, and the bacteria stick. But atrial septal defect, no. Now, let's say that you have ventricular septal defect and you're undergoing cardiac catheterization. Do you need to prophylax for cardiac cath? Angiography, angioplasty? No. That's good. I say no, you say no. That's good. Why? That's good. You should ask why if you don't agree. You should ask why. You don't agree? I don't agree either. I completely disagree. But when the test comes, I'm going to say, yeah. No cardiac catheterization. No prophylaxis. You want to give prophylaxis. You do. Cardiac catheterization. Is it
because it's supposed to be a sterile procedure?
What?
Is that because it's supposed to be a sterile procedure?
It is supposed to be a sterile procedure. Yeah.
Is that the reason why? Yeah. Okay.
In other words, when you're going to do cardiac catheterization, do you normally cause bacteremia? You shouldn't. Wash your hands. Use some gloves. You shouldn't normally be causing bacteremia. It's not like this. All right, gonna do a cardiac cath. All right, let's sterilize the site. All right. It's surgically prepared skin. You should not be causing bacteremia. That's the point. You agree with me now, right? So now you know I'm right. Say, you are right.
You are right.
You are right. You don't think I'm some sort of shallow, self-centered narcissist, weak-egoed person that I need you to be wrong in public just so I can feel good about myself. Do you? You don't. That's not what you think, is it? Yeah, it's basically true. Yeah, that's true. It's true. Cardiac cath. Yeah. It's not a bacteremia-causing procedure. Pacemaker. Is it a significant defect? A permanent piece of metallic wire in your heart. Now you have a permanent piece of metallic wire, a pacemaker in your heart, and now you go get a hemicolectomy and all of your teeth removed and a prostate biopsy, cystoscopy. Do you need to prophylax the pacemaker? No. It's better to be wrong with me than wrong on the test. You don't live with the consequences of this. I told you, you don't live with the consequences of your mistakes here. The pacemaker. Yes, your whole medical life you get told, foreign bodies lead to infection, foreign bodies lead to infection, foreign bodies lead to infection, but this is not a Foley catheter. It is placed sterilely, it stays in, it's covered up, it doesn't go to the outside world, it doesn't colonize. It's just not an extra risk for endocarditis, the pacemaker. It's not an extra risk. Now, let's say you have aortic stenosis and mitral stenosis, and now you have aortic stenosis and mitral stenosis, and now you're going to have a C-section. Should we prophylax you for endocarditis? Now you guys are not sure what to do, right? You're saying, should I say yes or no? Should I be wrong on purpose in order to be right because I was wrong about so many? Maybe I should be wrong on purpose now in order to be right? Is it sterile? Let's put it this way. Does the uterus normally contain bacteria? Are you looking at my face for the answers or into your own soul?
I'm thinking.
I'm face reading. Does the uterus contain bacteria?
No.
Huh? Yeah? Well, this is a psychological question, okay? How many of my psychiatrists here? Okay, you tell me later. It's a deep psychological issue. Do you feel that your mother's womb was toxic? It had bacteria. I felt it was hostile to me. My mother's womb was infected and toxic, and it's a psychological issue, you know? It comes from childhood. My mother's womb was filled with pus. Okay. So the answer is the uterus should not normally contain bacteria. It's a sterile environment. There is a difference between the uterus and the vagina. Isn't there? A little bit. There is a difference between the uterus and the vagina. The vagina is not a sterile environment. Okay? It's not a sterile environment. But the uterus is. So therefore, cutting into the uterus does not cause bacteremia. Cutting the mouth, the vagina, the rectum, causes bacteremia. Cesarean section should not need prophylaxis for endocarditis. I had a previous quadruple bypass, and now I'm going to get a hemicolectomy, a cholecystectomy, a prostate biopsy, a cystoscopy. And how about sigmoidoscopy? Does sigmoidoscopy need prophylaxis? If there's a perforation. Well, don't be perforating people on sigmoidoscopy. You shouldn't be perforating. Well, we got to schedule a perforation of your colon. We should be causing peritonitis and sepsis at 11. Flexible. That's true. You do have to prophylax the rigids. And who's doing rigid sigmoidoscopies? Did you say after marriage? Okay. And the answer is, not me. Not me. So rigid sigmoidoscopies and rigid bronchoscopies do need to prophylax. Rigids prophylax, flexibles don't. Now, bypass. I had previous bypass, and I'm going to get all of these bacteremia-causing procedures. Do I need to prophylax a bypass? Previous bypass? No. No. You don't need to prophylax the previous bypass. Well, let's think about it this way. You know, when I was in medical school, at that time, the coronary arteries used to be on the outside of the heart. They're still on the outside of the heart? Yeah. Well, yes, they're still on the outside of the heart. So you can't get endocarditis from something that's on the ecto. So it doesn't matter how many bypasses you have, you still can't get endocarditis from it. Last one. By the way, these are the ones that are harder. These are the ones that are harder. You don't need me to say prophylax previous endocarditis, prosthetic valves, aortic stenosis, mitral stenosis, mitral regurg. Sure, those need prophylaxis. But what about sub-aortic stenosis? Hypertrophic obstructive cardiomyopathy. Prophylaxis, yes or no? Most yes, some no. Doesn't seem overwhelming. Let's rephrase. Let's rephrase the question. IHSS. Can it kill you? Can you have sudden death? Oh, that you're sure of. You're sure you can have sudden death? You're just not sure whether death is significant. I'm sure it can kill you. I'm sure it's enough of a problem to cause sudden death. I just don't know if that's a significant defect. It may not be significant. So if it's enough damage to flow to cause sudden death, then it's enough damage to cause endocarditis. And you need to prophylax. What is the strongest indication for surgery for endocarditis? What's the strongest indication for surgery? Embolization is a strong indication for surgery. But you know, you can give prolonged antibiotics and still be able to cure it sometimes. Fungal. Somebody said fungal. Fungal is a very important reason to do surgery, and you should really try, in every person who you can, to do surgery for everybody who has fungal endocarditis. But sometimes you can cure it and reverse it with long-term amphotericin. You can with long-term. You don't want to, but if you have to, you can reverse it with prolonged antibiotics. What is the strongest indication for surgery? Huh? What? Recurrence. Recurrence is a strong indication for surgery. But you can, with recurrence, still give them antibiotics for a long time and fix that recurrence. You can. What? Persistent positive blood cultures is a strong indication for surgery. But with prolonged antibiotics, you can still reverse it. Abscess, abscess is an even stronger reason for surgery. But with prolonged antibiotics, you can still sometimes reverse the abscess, the vegetations, you can still fix, the recurrence, the bacteremia. How long do you have to give antibiotics? If somebody develops a ruptured valve, how long do you have to give antibiotics before the chordae tendineae leap up and reattach to each other? You guys have no sense of humor whatsoever. I've got to tell you. G.K. Chesterton says, the angels fly because they take themselves lightly. I got to tell you got an anal manometry, you can shoot golf balls across L.A. County. All right, so the thing is that with the heart failure is the strongest indication for surgery. Emboli, positive blood cultures, even abscesses can be treated with prolonged antibiotics. But no matter how long you give antibiotics, the ruptured valve does not reattach itself. No amount of antibiotics will reverse an anatomical lesion like ruptured chordae tendineae, ruptured papillary muscle, ruptured valve leaflet, and a flail leaflet. Antibiotics will never fix that. Hippocrates says, dangerous diseases require dangerous cures. Anatomic diseases require anatomic cures. I'll see you in the next case. In terms of determining whether or not the sensitivities of the cultures are appropriate, it's important to get up to 3 sets of blood cultures to make sure that the patient is truly negative. If you do blood cultures and one of them is positive, then it's positive. However, the issue is, how do I say that they're negative? one set of cultures only achieves 60 to 70% sensitivity. Meaning, if the culture is positive, we don't have a problem. If the culture is negative, we can't be sure it's a true negative. In order to make sure it's a true negative, we need several cultures. 2 sets of cultures will bring us up to 85 or 90% sensitivity. The 3rd set of culture brings us up to 95% sensitivity. It's like bowling. You need that 3rd culture to pick up the spare. One little pin standing. And that's what the 3rd set of cultures does. So this is in terms of sensitivity. If you're positive with 1 or 2 cultures, then you're positive. But to make sure that the blood cultures are truly negative, 3. Clear? Clear. Next case. A 72-year-old man with metastatic prostate cancer comes in with rubor, dolor, calor, and tumor of his legs. Swelling, erythema of the leg. From the next down. He's got prostate cancer. He's got metastasis. Leg is swollen and red below the knee. How do I know for sure? How do I know for sure that this is not a clot? How do I know this isn't a clot? Because we're in the infectious disease section, that's why. If this was the cardiology or the oncology section, it might be a clot. This is the hematology section, but since we're in the infectious disease section, it must be an infection. The other thing is, you often can't, because clots can make you swollen, clots can make you red, clots can make you tender. Although I will generally tell you that clots don't make your leg warm. It's the warmth that tends to go against the clot. However, people can have clots. People can have clots that look exactly like a cellulitis. So the big differential in terms of cellulitis is the difference between the cellulitis and the clot in the leg. Once you know that there's no clot for sure, then we are confirmed as having cellulitis. Now, what is the most accurate diagnostic test for looking for a venous clot of the legs? Venogram, duplex, or impedance plethysmography? Impedance plethysmography. Plethysmography. Well, that's a very wet answer, isn't it now? But I don't like to order any test that I can't pronounce. Okay? So therefore, it can't be the impedance plethysmography because I can't pronounce it. The second thing is it's not as sensitive as the other tests. So the test that is the most sensitive is the venogram. The most sensitive is the venogram. However, you generally never do the venogram. You're generally never going to do the venogram. Although the venogram may be the most sensitive test, the venogram involves the injection of contrast agents. The venogram has a risk of renal failure. The venogram has a risk of causing allergic reactions. The venogram, in fact, causes problems because although it may give a few points of sensitivity and specificity, the venogram causes more allergic reactions, and it's often not worth it just for those few points of sensitivity and specificity. The duplex ultrasonogram has no allergic reactions, no renal failure, and has 95% sensitivity and specificity. So therefore, impedance plethysmography is essentially an archaeologic test. It's a dead test. And the venogram is not necessary because you have all the sensitivity you need with the duplex ultrasonogram, although it is the most sensitive test. Now, what organisms cause cellulitis? Staph and strep. So since it's staph and strep, the treatments are oxycloxidicloxanefsky. When are you going to use methicillin? Never. Because methicillin makes you
Urinate eosinophils. So you only use it if you like to urinate eosinophils. Okay? So, and same thing as it was here for the staph and strep here. It is with the cellulitis. We use ox, clox, diclox, and naph. When we're talking about methicillin sensitive and methicillin resistant, we mean sensitive or resistant to these drugs. It's the same thing that we said for endocarditis. Next case. What is this? It's a what? It's an egg. Some people say it's an apple. It's an abdomen. Yes, it is an abdomen. It's a Rorschach test. Pain, tenderness, fever, elevated white count. Pain, tenderness, fever, elevated white count. Pain, tenderness, fever, elevated white count. Which one? What is that? You have acute abdomen? Well, thank you. You have acute abdomen too. What is that? Could infection. Yes, that's actually all you can say. You can't say which one it could be. Could be. Can't tell. Can't tell. Can't tell. Can't tell. What if I tell you that all the pain and tenderness is here? What is it here? If all the pain and tenderness is here, right under the uvula. I mean the xiphoid process. Heart attack. Heart attack is not tender. Stomach does not cause fever and a white count. Cholecystitis is not there. Cholecystitis is going to be here. Pancreatitis. Now, if the pain and tenderness is up here, is that cholecystitis or choleangitis? Both. How will I know that it's the choleangitis? Jaundice. Choleangitis will be jello. Jaundice. When they're jello, then it's called angitis. When it's called angitis. Okay, yellow when they're called angitis. Or if no yellow, cholecystitis. Now, over here, of course, is appendicitis. And what if we say the tenderness and the pain is down here? What's there? Diverticulitis. 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 What is, what's down there? What? What's there? I can't hear you. But I have PID or cystitis? But how are you going to tell the difference between PID and cystitis and all the others? No. Cervical emotional tenderness. Or certified medical technician. Cervical emotional tenderness. Okay? Tenderness on with your cervical emotions. With emotions of your cervix. My name is Dr. Charcot. And this is my triad. Charcot-laden crystals and asthma. Charcot joints, neuropathic joints and diabetes. Charcot's triad with ascending cholangitis. Charcot got around a lot. Charcot-Marie Tooth syndrome. Okay, I understand he used to date Cosmo. So, we have it again here. It's jaundice, fever, chills, right upper quadrant tenderness. Jaundice, right upper quadrant tenderness, shaking chills. My name is Charcot, and this is my triad. So even before we get this is a good question, by the way, for which of the following is the most likely diagnosis. What is the most accurate diagnostic test? What would be the most accurate diagnostic test for an ascending cholangitis? ERCP is the most direct way of visualizing the biliary system. ERCP is the most accurate way of visualizing your biliary system. We get a big scope down you, go into your duodenum, put a cannula into you, go up that biliary system, squirt dye into you, and just see how beautiful you are on the inside. Visualizing that biliary system with ERCP is the most accurate. ERCP visualizes the biliary and pancreatic system. Now, let's say that you're not sure, and you're like, I don't know. Maybe it's hepatitis. I don't know. Maybe it's hepatitis. Maybe it's not. I don't know. Now, a white count of 14,000, a mild left shift, mild elevation, that could be anything. Any infection, any stress, having a seizure, sepsis, any infection. A myocardial infarction can cause a mild elevation of white count. Getting double parked. Getting a ticket. Now, if you weren't sure about whether this is hepatitis before, the bilirubin won't help you. But an elevation of the alkaline phosphatase with the normal other transaminases, an elevation of the alk phos with other normal transaminases tells you this is not hepatitis. This has to be a biliary obstruction problem. A biliary obstruction problem, because biliary system has two enzymes, alkaline phosphatase, and what's the other enzyme for the biliary system? GGTP. The biliary system is alkaline phosphatase and a GGTP. So this is telling you, I don't have hepatitis because my transaminases are normal. I do have an alk phos, but I'm not giving you the GGTP. Why is the BUN up? The BUN creatinine ratio. Why is the BUN up? Hypoperfusion. The person is fairly septic. The woman is infected. The person is infected. So hypoperfusion of any kind caused an elevation in the BUN and creatinine ratio. Elevation in the BUN and creatinine ratio from hypoperfusion of any kind. Now, this question keeps coming up on the break about on CCS, does it matter what order you put in the tests? If you write all of these tests at the same time and you hit enter, they're all done at the same time. It just doesn't matter if you put them all in and hit enter at the same time. They're all taken as being initiated at the same time. Now, there is something else that you should do at the same time as this. If this was CCS, what other test would you do at the same time? I would ultrasound first. Correct. Now, ultrasound is not as sensitive as ERCP. Ultrasound is not as sensitive as a CT. Ultrasound is not as sensitive even as magnetic resonance. But if you see biliary obstruction and a stone on the ultrasound, you don't need any of those things. You see it. Its specificity is just peachy. So I would order an ultrasound at the same time as all of these tests. What else would you order at the same time, right now? Blood cultures. Why? Septic, that's right. Chills. When you see chills, what does chills mean? Very good. Bacteremia. When you see chills equals bacteremia in the case. When you say chills, it means rigors, chills, rigors. And when you see that chills equal bacteremia. Ultrasound should be done. Blood culture should be done. What else should be done at the same time? All at the same time. Huh? Treatment. Could you be a little more specific? Treatment. My mother's going to say treatment. Antibiotics. Yeah, antibiotics. Fluids and antibiotics. That's a damn good thing. Fluids and antibiotics. That's a good thing. Fluids and antibiotics. Now, antibiotics. Which flavor of antibiotics would you like? What flavor? Because you know what? On CCS, you just can't order antibiotics. You got to be specific. Same way you can't go to a restaurant and say, when you say treat, that's like going to a restaurant and say, what would you like? And you say, food. I want food. What antibiotics? Not macrolides. What'd you say? Broad spectrum. I don't know what broad spectrum means. I want broad spectromycin. You can't write a prescription for broad spectrum. I don't know what that means. Oh my goodness, this is how you couldn't even make it through a restaurant. What would you like to eat? A lot of food, big food. Broad spectrum. I want big food. Gentamicin is okay because aminoglycosides get gram negatives. But I will tell you, it's actually, let me tell you a reason why it's not so good here. This woman has some renal insufficiency, and it's not such a good idea. Third generation cephalosporins is a better idea. Third generation cephalosporins are more gram negative. They are more gram negative. Actually, for that matter, in this case, second or third generation cephalosporins. Second or third generation cephalosporins are a good idea. Okay, for a person who has biliary sepsis. The anti-pseudomonal penicillins, piperacillin, ticarcillin, azlocillin, and meslocillin are all gram-negative oriented penicillins. They're all gram-negative oriented penicillins. The monobactam, aztrionam, is another gram-negative agent. And these are the gram-negative drugs. Now, almost any of them is okay. The gram-negative drugs, almost any of them is okay. Ciprofloxacin is a gram-negative drug, and it too would be okay as a fluoroquinolone or on the other quinolones. All quinolones get gram-negatives. By the way, this is the same answer for pyelonephritis. This is the same answer for peritonitis. This is the same answer for ascending cholangitis, cholecystitis, because for as long as you have had a urethra and as long as you have had a colon, E. coli and the other gram negatives have been the causes of pyelonephritis, peritonitis, cholecystitis, ascending cholangitis. And all of them are acceptable. But now these are not. And you say, well, which one? I can't give you one. I can't give you one, and I can't just say broad spectrum. Because what does it mean? But if they put A, oxacillin, B, cloxacillin, C, vancomycin, D, linezolid, E, one of these will be the right answer. Which one? I don't know. But these are gram-negative drugs. They'll all get E. coli. Antibiotics, fluids, ultrasound, all at the same time to find out that you have ascending cholangitis and obstruction of the biliary system. ERCP to pull this out. Okay. And also, when you combine piperacillin, ticarcillin, azlocillin, meslocillin with beta-lactamase inhibitors, these beta-lactamase inhibitors, the clavulanic acid, the sulbactam, the clavulanic acid here as well, the tazobactam, the sulbactam, all of these drugs also include the staphylococcal coverage as well. That's what those beta-lactamase inhibitors do. Questions on this case? You add flagyl to cover anaerobes and for a lot of intra-abdominal things. And now you would add flagyl, except for an interesting thing here, which is that these drugs are just as good for anaerobes as metronidazole, as flagyl. So you would add flagyl, which is metronidazole, when you have a drug like this that does not cover anaerobes. Does not cover anaerobes. Questions for me? Next case. Next case. Chief complaint. I've had a fever, a headache, and a stiffy for 2 days. Chief complaint is, I have meningitis.
14-year-old guy who comes in and says, I have a fever, a headache, and a stiff neck for the last day and a half. I have meningitis. Comes in, he says, I have a fever, a headache, photophobia, says, I have meningitis. So you have 3 times in a row where it says, I have meningitis, just like step 3. They hand you the diagnosis 80% of the time. 80% of the time, they hand you the diagnosis and say, what you going to do about it, doc? No focal deficits? Okay. Here's the issue. CT scan or lumbar puncture first? CT scan or lumbar puncture first? LP first. No? Are you disagreeing with me in public? Who did that? Who needs a CT scan before the lumbar puncture? Not everybody. Who needs a CT before an LP? Huh? Papilledema for sure. If you have papilledema, you should not be having papilledema from your meningitis. Who else needs a CT scan before an LP? Focal findings. You should not be having focal findings. But you can have focal findings with meningitis. But if you have focal findings, it means you might have a mass lesion. And we can't put a needle in your back if you have the possibility of a mass lesion, because you might herniate. You might herniate. So focal findings, you might herniate. So therefore, if there's any focal neurologic deficits, we should scan the head first to make sure that we're not going to put the needle in his back and he's going to herniate. Who else needs a CT before an LP? Unconscious, yes, because it's a very hard time doing a neurological exam if somebody's unconscious, right? Squeeze my hand. Touch my finger. Touch your nose. Can you feel this? Pull my finger. Pull my finger. You can't do that if you're unconscious. Or you can't do that if you're very severely confused. You see, severe confusion means that you're unable to get an accurate neurological exam. So severe confusion means you should get a CT scan first. Severe confusion, you should get a CT scan first, because you can't tell for sure if the exam is accurate or not. All right. Now, in the absence of that, you should get a lumbar puncture. Now, on the lumbar puncture, what is the most specific diagnostic test? Culture is the most specific? Or cell count? On the CSF, the most specific is... Who says that glucose and protein the most specific? No? No. Right. No. The most specific, is it a cell count or a culture? Who says cell count? Cell count? Cell count? Most specific? Come on, vote like this so nobody can see. Come on. Vote like this. It's a vote. It's very secret like this. No one can see. Come on. What? It's not sterile. The most specific test has to be a culture. Because I said 400 times that the most specific test has to be a culture. The most specific test has to be a culture. So the culture is the most specific. However, when do you wait for results of culture? Never. So it's the most specific, but I can't wait for the results. Since I can't wait for the results, I have to be able to tell now. What can I use now? What's the most specific test I can use right now? The most specific thing, now. Cell count or gram stain? Gram stain actually is more specific than a cell count. Gram stain is more specific than a cell count, but the problem with the gram stain is that for every 100 people who have meningitis, it only has a 60 or 70% sensitivity. So therefore, it's going to be negative. 30 to 40% of the time, it's going to be negative.
30 to 40% of the time. And that's the problem with the gram stain, is it's going to be negative 30 to 40% of the time. Protein and glucose are too nonspecific. Gram stain is specific, but it's not sensitive. Culture is specific, but it takes time. Cell count. You treat based on that cell count. You see, since you don't have the results of culture, and since the gram stain is often falsely negative, and since the protein level is nonspecific, you end up treating or not treating on the results of that cell count. Treat what? How can you say it? Treat? I said you treat on the results of the cell count. And you go, treat. That's like me saying, sex, male or female? And you go, yes. It depends. You don't know. You don't know what it's going to be. I haven't said anything yet. You treat based on the results of cell count. Treat. My mother, right or wrong? Cell count is either going to be thousands of polys, thousands of neutrophils, or a few dozen to a few hundred lymphocytes. Now, like in this case. In this guy, where he's got thousands of polys and a negative gram stain, what is the next best step in the management of this patient? Stop saying treat. My mother can say treat. You have to say a drug. You can't just say treat. What do you think it's going to be? Answer A, treat. B, don't treat. C, get a consultation. D, euthanasia. Ceftriaxone. Thanks for covering up on. There you go. Didn't we say this? Ceftriaxone. 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 Ceftriaxone first. Ceftriaxone. As empiric therapy for bacterial meningitis. Now, in adults, what's the most common cause of bacterial meningitis? Strep pneumonia. Strep pneumonia. And in children, in 4 or 5-year-olds, what's the most common cause of meningitis? What? Strep pneumonia. Strep pneumonia. Strep pneumonia. Haemophilus influenza has been eliminated. 95% of Haemophilus influenza has been eliminated. So strep pneumonia in kids too. Strep pneumonia in kids too. So ceftriaxone. Yes, yes, yes. Thank you very much. Thank you very much. Now, a couple of dozen to a couple of hundred lymphocytes. That could be cryptococcal meningitis, cryptococcus. That could be Rocky Mountain spotted fever. That could be Lyme disease. That could be viral meningitis. That could be syphilis. That could be TB. That could be a lot of things. So basically, a couple of dozen to a couple of hundred lymphocytes can be anything. Now, this is partly why we skipped certain of the other cases later on, because anything that's important about them we're saying now with each disease. Cryptococcal meningitis. What is the most accurate diagnostic test for cryptococcal meningitis? The most accurate diagnostic test? India Inc. is not the most accurate diagnostic test. India Inc. is the best initial test, but it's not the most accurate. Antigen testing. Now, this one we start out with the easy one. What is it that's going to tell you in the case to get the cryptococcal antigen and the India Inc.? What will tell you? What will be in the history and physical? HIV. Sure, it'll be HIV. It'll be HIV. And you got an HIV positive guy with meningitis, an HIV positive guy with meningitis, and an HIV positive guy with less than 50 T cells having meningitis, and it tells you get the India Inc. and the cryptococcal antigen. There's HIV in the history telling you to get that test. HIV in the history signals you to get that test. Best initial therapy for cryptomeningitis, amphotericin or fluconazole? Or flucytosine? Or itraconazole? Or liposomal amphotericin? Or Terazol vaginal cream?
Both fluconazole and Terazole vaginal cream. Yeah. Say it again. Would you be more specific than that? What's the role of penicillin is a difficult question. If the person is sensitive to penicillin, then you'd use penicillin. If the person is sensitive, then you can use penicillin. I'm emphasizing ceftriaxone because you don't have the results of culture yet. Oh, that's a good one. You know what that is? When you go like that, you don't have the results of culture, so ceftriaxone is the best empiric therapy. That is a sign of irrigation between different portions, between going across the irrigation across your corpus cavernosum. You don't have the results. Remember, since you never wait for results of culture, in infectious diseases, it's always empiric therapy. You take the culture and you give the antibiotics while waiting for the results of culture. You take the culture and you give the antibiotics while waiting for the results of culture. It's always empiric therapy. It's always empiric therapy. Okay? So, amphotericin is the therapy first. Not fluconazole. You could give fluconazole. I mean, you can give it to them instead. You could do that. They would die. But you could do it. But not fluconazole first. Amphotericin first. Can you see rickettsii, Rocky Mountain spotted fever? Can you see it on a gram stain? No. Why not? It's intracellular. So you can't see it on a gram stain since rickettsii is intracellular. You can't see it on a gram stain. Can you grow it on culture medium? No, because culture medium normally does not have cells in it. And since it lives inside cells, you can't grow it in regular culture medium. Lyme disease is a spirochete, Borrelia burgdorferi. Can you see Borrelia burgdorferi on a gram stain? No, because you can't see spirochetes. You can't see syphilis and you can't see Lyme on a gram stain because spirochetes don't show up on gram stain. They're too small. And they don't get cultured. They don't culture out very well. I can't see it on a gram stain. I can't grow it in culture. I need specific immunologic tests against that organism. I need IgMs acutely and IgGs later on to make the diagnosis of that organism. So I need specific serologic tests against that organism. Sounds very simple, doesn't it? Except for one problem. What will tell you to get the rickettsii serology? What in the history will tell you? The tick is the most common wrong answer. The rash will help. The problem with the tick bite is that only 20% people remember that they had contact with the tick. Most people do not remember that they have had contact with unprotected contact with an unidentified tick. Okay? What? You're projecting again. You're projecting your own perversity onto me. It's not me. It's you. I'm not projecting, you're projecting. So therefore, remembering the tick bite, the people come in, they come to the office and they said, I don't know. I mean, I must have had contact with some sort of tick because something got... So you're going to look for the rash. And what's going to be characteristic about the rash or Rocky Mountain? Palms and soles, no. Wrists and ankles, yes. So wrists and ankles. But what's characteristic about Rocky Mountain spotted fever? What? Starts out here, moves in here. Oh, yes. Do that again. One more time. Not now, dear. Daddy's working. Okay. So he's sitting there going. That's right. Starts out here, moves in here. Legs and ankles, moves in here. Lift an ankle. Moves.
essentially. Yes, I know. But just remember that when test day comes and you're like, gee, does this person have Rocky Mountain spotted fever? It'll stand out in your memory. Lyme has a target rash. A target rash. It's pale on the center and red on the outside. Red on the outside and pale on the inside. Red on the outside and pale on the inside. The erythema migrans. I don't like to say erythema migrans because people go, oh, erythema migrans. What the hell does that mean? I don't know. It used to be erythema chronicum migrans. Oh, erythema chronicum migrans. What the hell does that mean? It means it's red in the outside, red ring with a pale center, like a target. It's better to say a target than to say erythema migrans, because erythema migrans just means you have red skin that moves. That doesn't help me. Now, what else is going to be in that history to tell you it's Lyme and Rocky Mountain spotted fever? Huh? That's true, but the problem with endemic areas is it's very hard for people to relate to. Let's put it this way. You're in California right now. Which is endemic to California, Lyme or Rocky Mountain? Neither one. Now, you see, on the East Coast, people can figure it out a little more because one of them is endemic wherever you are. But when you're in California, that's the perfect reason that to learn this without having to know the geography. I mean, Lyme is where? In Lyme. Yes, Lyme is in Lyme. And Lyme, by the way, it's lime, not limes. Limes are something you slice and put in a Corona. Okay? Lyme is a place in Connecticut. It happens to be a suburb of Yale New Haven Medical School. It's in New Haven, Connecticut. It's Yale Medical School. Okay? And so Lyme is in Connecticut and Massachusetts and Westchester. And people tend to know where those places are, roughly. But do you really know where Tennessee is? Do you know where Arkansas is? Do you know where Alabama is? Do you want to know? Do you know where North Carolina is? You know where that place is? Most people don't even know. Look at it from New Zealand, right? Where the hell is North Carolina? Tobacco land, that's right. But you still don't know where it is. I don't know. Where's it? Okay, it's like me knowing where Mount Fuji is. Like, how do I know where Mount Fuji is? It's in Japan somewhere. You know what I mean? So look at it. So the thing is, it's better for you to do this without the geography. It's better to do it without the geography. If you know where Connecticut is, great. Massachusetts. If you know where North Carolina, South Carolina, Kentucky, and Tennessee is, good for you. Because most other people don't know. You look for something in the history and physical with a chief complaint, Johnny, you get off of your system. That might help you. Okay? Now, but there is something else in the history that you could do it without the geography. Without the geography, what helps you? Outdoor activities? Like what? Camping. Camping and hiking. That's it. When you see camping and hiking on a step 3 question, it has virtually 100% mortality. Everybody dies. When you see camping and hiking on step 3, you come back with either Lyme, Rocky Mountain spotted fever, or giardiasis, depending on what you do in your camping trip. So this is how you're going to recognize it. If you know the geography, good for you. But I was 32 years old before I realized where Alabama, Arkansas, and North Carolina were. All I knew is they were south of Canal Street somewhere. South of Houston, but I don't know how far south. Okay? Just go for Jesse Helms and make a left. Okay? Camping, hiking, and therefore you can do this without having to know the geography. You see, that is the more important thing. Because knowing that you get serology, and syphilis is serology too, it's just that you have a name for that serology. It's called the VDRL. That's not hard. Saying, I'm going to get specific IgMs and IgGs for these organisms. That's not hard. The hard part is what will tell you to get that specific serology. That is the key. That is the key. It's a rickettsia, chlamydia rickettsia, doxycycline. Lyme disease is a spirochete of my brain, so I treat it with ceftriaxone. Although, like tertiary syphilis, I could use intravenous penicillin. I could use intravenous penicillin, like tertiary syphilis, ceftriaxone or penicillin. TB is managed basically the same way as pulmonary TB is managed, meaning AFB stains, AFB cultures. The same way that pulmonary TB is managed. When are you going to give intrathecal antibiotics? When will you be squirting antibiotics directly into the spinal column? TB meningitis? No. Let me give you a new question. Let's switch that question. When do you use steroids for meningitis? TB meningitis. Steroids for TB. That's it. When do you have to give intrathecal? Intrathecal meningitis. All meningitis is intrathecal, brother. Intrathecal means in the central nervous system. Never. You don't have to use intrathecal antibiotics. If your meninges are inflamed, anything will pass. Even stool will pass. Anything will pass. As long as your meninges are inflamed. TB meningitis, AFB smears, AFB cultures, 4 TB drugs, the same as TB anywhere else. Be managed in the pulmonary section. Same way, isoniazid, rifampin, pyrazinamide, ethambutol. Syphilis was in 1941, intravenous penicillin. In the year 2001 is intravenous penicillin, and it's not going to change. The problems with Rocky Mountain and Lyme disease is how to recognize the case so you can get the specific serologic test. That's the hard part. Well, let's change this case a little bit. Let's change this case a little bit. And let's change this case. And we are going to make this guy, ready? We're going to leave everything the same, everything the same. We are going to leave every single thing the same, except we're going to change one single word. One single word. Go back up here. Ready? Look up here. Cover up. Forget about that case in your hands. You ready? You ready? Look up. Look up. Everything is the same. Everything is the same. Look up. Look up, and we take out that one word. This history, this physical, we take out that one single word and say, what is the next best step? CT is the wrong answer I'm looking for. IVA cyclovir is the 23rd most common wrong answer. Not CT next, not acyclovir next. There are focal deficits. Intubation. No, intubation. What are you intubating for? You intubate too early and too often. You got to slow down. Huh? Lumbar puncture. You can't do lumbar puncture first if there's focal motor deficits. All right? You can't do it. If you do a lumbar puncture when there's focal motor deficits, how do you know it's not a mass lesion? You do a lumbar puncture on this person, you might come out with later to a rectal exam and say, nice smooth prostate on your rectal. And he goes, that's not my prostate, it's my pons. I'm taking that out for the 12th time in a row. The case stays the same. And I take out that one word. And I'm asking one simple question. When I put in focal deficits, what are you going to do next? Ceftriaxone. You can't say treat. My mother could say treat. There is no answer on step 3 that says treat. A, treat. B, don't treat. C, get a consult. D, euthanasia. My mother could say treat. My mother's the chief of infectious disease at UCLA, but I mean she could say treat. Ceftriaxone. Ceftriaxone. The point is, when you are going to do the CT, when you think you have meningitis, and you have to do the CT first before the lumbar puncture, you will squirt them with antibiotics. Then, go on to the scan. Now you get the point of how you can know everything about it. Now those of you who are saying CT, you're right, but the question was different. When I said, what do they need next, you were hearing, who needs a CT before an LP? And that was correct. Focal deficits, papilledema, severe confusion, does need a CT before an LP. But that wasn't the question. I didn't say, who needs a CT before an LP? I say, what do you do next? And don't have that hurt look of, you tricked us.
Wouldn't the cultures become negative because of the antibiotic?
Wouldn't the cultures become negative? The cultures might become negative. That's a very good point. The cultures might become negative. Okay? The cultures might become negative, and you might have false negative cultures. And here's the question. How long does it take to develop permanent neurologic damage with bacterial meningitis? 6 hours? 6 hours? I accept that figure. 6 hours? I accept that answer. So would you rather have a false negative culture, or would you have an accurate culture and permanent neurologic deficits? Right? Okay, I'd rather have a false negative culture and have accurate and have no permanent neurologic deficits. And by the way, what is the most common neurologic deficit long-term in meningitis? What? I'm sorry? I'm sorry? I can't hear you. What? What? So if we withhold the antibiotics, go like this. Come here, I've got the result of your culture. What? I've got the result of your culture. Come here. What? I've got the result of your culture. Come here. Neurologic damage can happen in 6 hours. It is better to give the antibiotics. Now here's the other answer, okay? We could do it the traditional medical school way, right? What's the traditional medical school way? You'll never learn it that way. A lumbar puncture for culture is the most accurate specific diagnostic test. However, the culture takes 2 to 3 days to return, and we need to use the cell count to determine the necessity for initial therapy. You should do a CT scan before a lumbar puncture if there are the presence of focal neurologic findings, papilledema, or severe confusion. However, if you're going to do a CT scan first, you should initiate empiric therapy prior to the CT scan to prevent the development of neurological damage. It's like, what? Now, what that is everything I said before. But there's data, and there's how to use it. If just hearing the truth was enough for us, then all we would have to do is sit in temple, church, shul, mosque all day long and listen to sermons, and we'd all become saints. But it doesn't work that way, does it? No, I don't think so. Got to work, just like RuPaul says. Ceftriaxone first, then a CT, because it is better to have a false negative culture. Besides that, it takes 24 hours for the CT to sterilize, the CSF to sterilize, and you still have a cell count in the gram stain. Okay, let's change this question a little bit. And we're going to make this guy, everything stays the same. Everything else stays the same. And we're going to give him 3,500 polys, and everything else stays the same. Everything else stays the same, except we're going to make him an HIV positive, elderly, neonate with AIDS, 22 T cells, and a history of pneumocystis pneumonia, and everything else stays the same. This history, this physical, these labs, this history, this physical, these labs. What is the next best step? Ceftriaxone is wrong. What did you say? Who said treat? You know. There's no answer that says treat. What, orthonovum 777? Triphasal? What do you mean? Amphotericin B is almost right, but completely wrong. But it is the wrong answer I'm looking for. Alhamdulillah. It is the wrong answer I'm looking for. Amphotericin is wrong. Ceftriaxone is wrong. Ampicillin is wrong. Huh? IV erythromycin. No, wrong. Steroids. Which kind of steroids? These types of steroids? No. Ceftriaxone and ampicillin. Why is this not cryptococcal meningitis? It's not cryptococcal meningitis. Why not? There's 3,000 white cells that are neutrophils. It's thousands of polys. In an immunocompromised person, ceftriaxone and ampicillin. Ceftriaxone won't cover listeria. Ampicillin won't cover the other things. Amphotericin, this is a very important point. In 1 second. Okay, ready? He saw the HIV, which is a very important risk factor for cryptococcal meningitis. But the individual presentation is a bacterial meningitis. You're looking at questions, and what's more important, the risks or the individual presentation? The individual presentation is the most important thing, and that's the point of this case. Have a relationship. I invite you to cultivate a love affair with being wrong. The wronger you are now, the righter you'll be later on. Thousands of polys is bacterial. Immunocompromised puts you at risk for listeria. What's the most common cause of bacterial meningitis in HIV? Strep. Ceftriaxone and ampicillin. Next case.